Okay, this video is when to give IV contrast for brain MRI. A couple of viewers have sent me emails asking me this question, and it's a rather technical question, so I'm going to make a video about it. I also searched the internet and I couldn't find any detailed information. There's a few little things here and there, but there's no detailed information. So first of all, what's the logic of IV contrast? It shows you where there's a breakdown in the blood-brain barrier. Breakdown in the blood-brain barrier will then enable the contrast to be taken up. Where the blood-brain barrier is intact, it won't be taken up. And when contrast is taken up in the tissue, and you can see it on imaging, that's called enhancement. So where there's pathology, disease, that's abnormal enhancement. The goal of a brain MRI is to make a correct diagnosis, but you want to avoid giving excess contrast material. Contrast material is called gadolinium. You especially want to avoid repeatedly giving IV contrast material because it can start to accumulate in the brain when it's given repeatedly for patients who keep coming for follow-ups. And a lot of times on the follow-up, if you're following something like a meningioma, it's a common benign tumor intracranial, you already know where the tumor is. The question is it bigger or not? So I would say most of the time you don't necessarily need the IV. But don't get me wrong, there are exceptions. There's a nuance to all this. If the tumor is next to the superior sagittal sinus, for example, and you're worried that it's thrombosed, you might want to give IV and see if that's the case. If the tumor is really difficult to see, then it's probably small. But if it's around something important, you might want to give IV. So it does matter in that context. The other thing is people say, well, why do neurologists usually want to give IV contrast? And the reason is, if you talk to neurologists, and I talk to neurologists all the time, here's what they'll tell you. Most of their patients are old. A lot of them don't travel well. It's difficult to get the patient and the family all together in the same room to have a meeting and discuss what the treatment plan is going to be. So they want a definitive diagnosis and then the ability to meet with the patient's family or caretaker, and make a decision about what to do. So that's good. On the other hand, when people who watch this video, you're probably going to be a younger, more with it person. A lot of old patients are mentally slow. So what I'm saying is, let's say I myself had to get an MRI. I wouldn't want IV. If I absolutely had to have it, I would get it. But if I could avoid it, I would avoid it. And, I'm a young walker talker who's with it. Well, I'm not that young, but I'm physiologically young. I would just come back and get the IV if I needed to. Okay, but that can be easier said than done. You might get stuck having to pay more money, especially if you don't have insurance. That can be a lot of money. And it might take you another month, 6 weeks, couple months to get on the schedule. So it does matter. Okay, you also want to go somewhere where there's a good magnet. Usually the university magnets are better shielded in the big hospitals, some type of big hospital. I'm not that big a fan of these outpatient MRI centers where you have open magnets because usually the pictures are not as good. So it depends what you're trying to image, but in general, if you're going to have to get an MRI, you want to get a good MRI. All right, but that's a whole other issue, talking about quality control with regard to the type of magnet. Now, when must you give IV? If you're looking for brain metastases, patient's got a known primary malignant tumor, then you need to give IV. Some people say, well, on DWI, diffusion-weighted imaging, you can see small cell lung cancer. Yeah, maybe, but that's about it. You really need IV. Otherwise, you're at high risk to get a false negative scan. If we're looking for metastases, and that's a common reason to do brain MRI, you need IV. If there's a primary brain tumor, like a glioblastoma multiforme, GBM, IV is helpful. And, it's helpful post-op, check for residual recurrent tumor. It's helpful for checking satellite sites of tumor. You want to give IV. If you're looking for infection, normally you will want to give IV. You'll be more sensitive for detection of infection. Brain MRI seldom sees infections. Brain abscesses, they're rare. I mean, how often do I see a brain abscess? About once a year, But they can be helpful. Most of the time what they want is they're going to do something like a head CT, CAT scan, just to make sure there's not mass effect intracranial before they do a lumbar puncture. But if you want to increase your sensitivity for infection, and there's some other rare infections, parenchymal infections, you would want to give IV. In general, those are the main reasons for ever giving IV for any type of MRI in the brain or spine, is possible metastatic tumor or infection. Other things are also relevant. If you have a new seizure, new onset seizure, you want to give IV because you don't really know what you're dealing with yet. It could be a tumor infection, could be a vascular malformation. There's different types of vascular malformations. We see little things like developmental venous anomalies, venous angiomas all the time, and those are no big deal. I don't even follow those. But if you're looking for the more rare stuff, things like a dural arteriovenous fistula, arteriovenous malformation, then you would want IV. Okay, what's next? When do you not need to give IV? And this is, most of the time we don't give IV. If you're doing a routine workup for dementia or Parkinson's disease, a stroke follow-up, just looking at ventricle size on a follow-up ventriculoperitoneal shunt, VP shunt, routine workup, a TBI, traumatic brain injury, routine workup, a headache. If you're just following up to check the size of a bleed as it resolves, intraparenchymal hematoma, IPH, SAH, subarachnoid hemorrhage, or SDH, subdural hematoma, you don't need contrast. We'll often just follow up some of that stuff with CT. CT is cheaper and faster. Okay, when is IV usually given, but it's often not required? And I would say be careful with patients that have to keep coming for repeats. Again, like a meningioma, it's a very common indication for a repeat MRI. You don't necessarily have to give IV. Sometimes you will want to, like I said, but if you can get away with no IV, I would try to do it with no IV because these patients might get followed for 15, 20 years. So that could add up to a lot of gadolinium injections. Okay, the next one is if you're looking for vestibular schwannoma, also called acoustic neuroma of the internal auditory canal. We get a very good scan with the no IV contrast sequences like T2 space or CISS. And ear, nose, and throat doctors are very happy with those scans. And that way you don't get any false positives. When you give IV contrast, you can sometimes get subtle false positives because you'll get a little bit of enhancement just due to the vascular structures in the canal and sometimes even volume averaging. And so then the patient can get stuck into follow-ups, and you'd prefer that not to happen. So if it was me, I would get it with no IV, and if there was some question, I'd do a follow-up. But you just have to accept the fact that when you don't give IV, your sensitivity is going to go down a little bit, but your specificity is going to go up, meaning that you might miss a really, really small lesion, but you're also much less likely to get a false positive, and you don't want false positives. A common area where I see false positive is imaging the pituitary. When patients go for pituitary imaging, if you're doing a follow-up, do you need IV? Most of the time they give it. Sometimes you probably need it, sometimes you don't. But one of the things I would watch out for is a diagnosis of hypogonadism, abnormally low testosterone, for example, of unknown reason. If it was me, I would make sure I wasn't eating soy, drinking water with aluminum and fluoride in it, that sort of thing first, putting a cell phone in the front pocket, microwaving your balls. I would check for all that stuff first, because the danger of going for a brain MRI, or we'll call it an MRI of the sella turcica, that's the location where the pituitary sits, is that when you give IV, you often get false positives. You can have volume averaging, even with a thin section MRI through the sella. You can also unmask benign things that you don't even want to know about. There could be some benign non-functional cyst in that pituitary, and you don't want to know about it. A non-contrast brain MRI is actually pretty sensitive for seeing clinically significant pituitary tumors. So I personally would be very careful about that, because that's a real common reason that you get false positives and the patient gets stuck, keep coming for follow-ups with IV contrast. And I think the whole imaging thing with hypogonadism is rather overrated. We almost never see anything. And then when we see something, it's more often a false positive than a real lesion. So let's see, what else? Acute stroke. Most of the time, acute stroke is going to be worked up with CT. The patient gets a non-contrast head to check if there's an intracranial bleed. Then they make a decision about thrombolysis. But they usually right away at the same setting get a CT angiogram of the head and the neck to check if there's any large vessel occlusions. Or they would even consider potentially transcatheter thrombectomy or something like that. And the point I'm making is these patients have usually had a head CT and a CTA head and neck before they might go for a brain MRI. So they've already had an evaluation of the blood vessels with the CTA. And the point being is that that's a reason why you don't need to give IV contrast for the brain. Now, don't get me wrong, if you're still looking for other things, like you're looking for METs or something, then you would give IV. But I'm letting you know also that you don't absolutely have to. You can do an MRI of the head using time of flight technique, which doesn't require IV contrast. Okay, to get a good neck MRI, IV contrast does make it a lot better. If the patient is, of uncertain diagnosis and delayed follow-up, you might be considering a subacute stroke, and IV contrast is very helpful for looking for subacute infarcts, because you see a characteristic pattern of gyroform enhancement typically in a subacute stroke. So it makes sense in that context. Multiple sclerosis. I'll often like IV contrast at the initial diagnosis. Maybe it'll show you an optic neuritis or something, or get a sense of how active the lesions are with IV contrast for the initial diagnosis. However, MS patients often come for numerous follow-up brain MRIs. And so a lot of times the follow-ups can be done without IV as a way to not expose them to so much repeated gadolinium injections. Okay. Now, the next question is, who do you want to avoid IV if at all possible? Patients with renal failure, especially if they got a GFR, glomerular filtration rate, below 30. You worry about nephrogenic systemic sclerosis, fibrosis. So, that's super rare, but still, we try not to do it. And in a life-saving situation, you would potentially do it. I would have neurology write a note, not neurology, nephrology, the kidney doctors write a note in the chart that they think, in conjunction with whoever was ordering it, that it's reasonable for this particular patient. And I've done that plenty of times, and it usually goes fine. But, I wouldn't do it if I didn't have to. History of allergic reaction to IV gadolinium, you would try to avoid it if you could. Could you answer the question with CT, for example? Do you really need IV? And if the patient's already got known accumulation of gadolinium contrast in their basal ganglia and the deep cerebellar nuclei, like the dentate nucleus, with characteristic T1 hyperintensity on a non-contrast scan, then you keep giving more, they're going to accumulate more, so you'd want to avoid doing that. So anyways, that's a pretty thorough overview of the common questions that come up about giving IV contrast for brain MRI, so hope you found that helpful.